Yeah, no, I hope the timing was good, but you actually were early, so really appreciate you being here. As many of you know, that Senator was actually our primary contact for our blood supply. So, and really appreciate him taking the time to come down here. So
it is my honor. I'm really happy to be here and glad that you guys invited me. Thank you so much. So I wanted to take the chance today to talk to you guys about one of my favorite subjects. I know I have a mixture of laboratorians and pathology residents here, and that's totally great because this topic fits really well for both. Some parts of the topic will fit better for the laboratorians, some topics of it will fit better for the pathology residents, but all in all, I think hopefully we'll all be okay in the end. Nobody will throw stuff at me. That'll be good. I'll consider it a victory if nobody throws too much stuff.
We also have a hematologist here.
Oh my goodness, well. So let me kind of take you through my thoughts on warm autoimmune hemolytic anemia primarily, but we'll talk about the other ones as well if we have time. But it kind of starts really for me with this general idea, and that's the topic of my talk is kind of silly, when selfies go bad. And really, I think that everyone would recognize that in recent years, and this works better when I turn it on, in recent years, things have changed in how people take pictures, right? I mean, if you look around everywhere anybody goes, and this is the part where I sound like a grandpa telling everybody to get off my lawn, so forgive me for a second, but everywhere you look around, people are taking pictures of themselves, like this at the Oscars a few years ago, that Ellen DeGeneres took the massive selfie, and that was fun, that was funny, okay. Okay, sure, Toy Story, no problem. Even presidents get into the picture and take selfies, and then people that pretend to be presidents to take pictures of themselves as selfies. And honestly, there's so many selfies everywhere you go. In fact, some of these, when you look up bad selfies on the internet, do a Google search, you get some of the most insane things. I want to show you a couple on this next slide that totally cracked me up. So this guy, so here's a guy. It's a good time to take a selfie, right? That's wise. That's really smart. And then I saw this other one which looked kind of familiar. Another one like that. I know you can't see this very well. It's the same dude, right? This guy is so stupid that he's taking pictures of himself. Both times he's getting tickets. I don't think this cop is okay. I don't think that guy's terribly pleased. And I have to admit, I have been guilty of this as well. I was in Hawaii about a year or so ago with my lovely bride, and we went out. We were there in February when the whales are out, which is just wonderful. And on one side of the boat, this was happening. So gorgeous. I didn't see it because I was on the other side of the boat doing this. Right? I'm doing the selfie thing, so I totally missed out. I got that from somebody else. The point is, and it's a silly point, that bad things can happen when we start paying too much attention to ourselves. And that's, again, I know I sound like a grandpa when I say that, but when our attention is focused inward too much, sometimes things happen that are challenging. And that's the basis of what we're going to talk about. We're going to spend most of our time today talking about warm autoantibodies and warm autoimmune hemolytic anemia, primarily from the laboratory perspective. We'll also, if we have time at the end, we'll get into the two different types of cold autoantibodies that cause pathology in cold agglutinin disease and paroxysmal cold hemoglobinuria, and then maybe a little bit on mixed warm and cold, if we have time at the end. But mostly this talk is intended to talk about warm autoantibodies and warm autoimmune hemolytic anemia. You will note that there are a lot of different types of hemolytic anemia. You see them listed here. We're not going to talk about really any of these, with the exception of autoimmune hemolytic anemia. Things like alloimmune, that confuses people. That's just basically a hemolytic transfusion reaction. That's an alloimmune process. And you see the others. But again, we're going to focus our attention on autoimmune hemolytic anemia, just in case you're not familiar with autoimmune. I doubt that. But antibodies produced against substances present in the person's own body. Spending too much time focused on yourself, in other words. This is kind of where we're going. And those of you that are residents, if you'll shoot me an email, I'm happy to send you this particular image because this, I think, is a really nice summary of the four main types of autoimmune hemolytic anemia: the warm, the cold, the paroxysmal cold, and the mixed. That kind of breaks it down on laboratory, a little bit clinical, but kind of how we approach these things. And I'm not going to spend any time going over each and every one of these because I'd fall asleep doing it, so I won't do that. But again, if you just email me through the Blood Bank Guy website, I'm happy to send you this image, and I think it might be useful for you, for those of you that are residents when you're studying. Anyway, okay, so here's case one. We have a 72-year-old female who was admitted with weakness and anemia, and she comes in, her initial lab, she has a super high white count, 62,000. Her hemoglobin is low at 6.9. Her peripheral smear shows some spherocytes scattered around her, and her total bilirubin is elevated. The clinicians are requesting a transfusion of 1 unit of red cells, and the specimen comes in to be worked up in the blood bank. So we run our antibody screen, our antibody detection test, in this case on gel with a 2-cell panel, and we get wildly positive, 4+ positive across the board, are on both of those cells. We run a panel, and we get, again, wildly positive, strong positives in every cell, including this cell down here. And again, for those of you that are pathology residents, please get in the habit. Every panel you look at, make sure you're checking that. That's really, really important. It's easy when you run against a panel, especially on a standardized exam, if you don't notice that the autocontrol, the patient's red cells against the patient's own serum, if you don't notice that that's positive, it can completely skew the entire process of what you do. I'm not going to take the time to go over how these are interpreted. The laboratorians know that. The pathology residents should know that. If you don't, we can talk about that later on. The DAT is done. That's, again, strongly positive, 4+ with polyspecific reagent, 3+ with anti-IgG, 1+ with anti-C3. Just for review, the direct antiglobulin test is simply a scenario where the red cells are taken directly from the body, washed, and we're checking to see whether or not there is either complement or antibody on the surface of the red cell. Really fairly simple in concept. We're not doing any manipulation of the cells in terms of adding additional serum. We're just checking through the use of this anti-human globulin to check for in vivo coating of the red cells. Were these red cells coated with antibody or complement in the body before we got them into our test tube? Most of you are aware that anti-human globulin comes in several forms, and it's important, I mentioned those in the previous slide. The polyspecific will generally pick up either antibody, primarily IgG, or complement, primarily C3d, and then you can break that down and do a specific anti-IgG or anti-C3 reagents. Most laboratories will start with a polyspecific, and if it's positive, then they'll move on and figure out whether it's anti-IgG or anti-C3d or both. Polyspecific is kind of like the screen for those of you that are residents. I think you're familiar with that. All right, a couple of really important concepts. The DAT being positive, and this is really easy to confuse, and it's really easy to think wrongly about this. The DAT being positive is not equivalent to autoimmune hemolytic anemia. In fact, if you did a DAT on every patient that came into the hospital, part of the reason we don't do a DAT on every patient that comes into the hospital is that you've got between 15 and 20% of patients that are going to come up positive on the DAT, and it means absolutely nothing. It just is. Why is it? It just is. There's no great explanation for it. So it's only important when you have a hemolytic process. So one of these things, not like the other. Now on the second thing is also important to recognize that, anybody picking it up? Anybody seeing it? No. Yeah, you got to have Nick Cage. On any presentation, there has to be Nick Cage. Anyway, so also understand, even the presence of autoantibodies does not equal autoimmune hemolytic anemia. That's kind of an easy assumption to make. Oh, look, we've got warm autoantibodies. This patient must be hemolyzing. Not true at all. It may be true, and I'll show you how to evaluate that. But it is absolutely possible, in fact, more common than the other way, to have warm autoantibodies without hemolysis. So if you have evidence and you have of antibodies and a positive DAT, it may mean that you have autoimmune hemolytic anemia, but then again, it may not. All right, so the warm and cold thing. Everybody, I think, is pretty familiar with the fact that when we say warm, we're simply meaning those are antibodies that react at body temperature, antibodies that react at 37 degrees. And warm autoantibodies in particular are really, they're pretty non-discriminate in how they like to react. They'll react against pretty much everybody's red cells. That's why we had that panel that showed everything being positive across the board. It's almost always IgG with a warm autoantibody, and the antibody will bind to the red cells, but they're generally speaking not complement-fixing antibodies. That's a really important distinction to understand, because you guys know we have 5 main types of antibodies: IgG, IgA, IgM, IgD, and IgE. And IgG, because, by nature of the fact that it's kind of small, much smaller in fact than IgM, it doesn't do a great job at grabbing onto a red cell and then binding complement all the way through to the final stage of complement fixation, which is this, where you blow a hole in the red cell. IgG is much more associated with extravascular hemolysis, where the antibody binds and it just kind of sits on the surface. It may take complement to the stage of where some complement gets fixed on the cell, like C3d, for example, that I showed you before, but it generally doesn't go all the way through to where the red cells blow apart. That intravascular hemolysis, that's what we think of with ABO incompatibility, when we've got IgM antibodies involved, and some types of IgG antibodies involved, but more commonly IgM. On the other hand, with IgGs, you usually get extravascular hemolysis, where the hemolysis occurs either in the liver or the spleen, as opposed to red cells just blowing apart where they are. And there's been a lot of discussion on how this happens. The short version of it involves macrophages, especially in the spleen, somewhat in the liver, that will bind to the Fc portions of antibodies that are binding red cells. Okay, so the antibody, the macrophage binds to the Fc portion of the antibody, and subsequently the red cell gets damaged. And there've been a lot of pictures like this, or cartoon images that show it. But my favorite pictures of this were some scanning electron micrographs that were done a number of years ago that actually shows a splenic macrophage jumping onto a red cell and actually biting off a portion of it and spitting out the rest. In other words, it's biting off the portion where the antibodies are bound and it's leaving the rest alone. I love that picture because that really shows me that the reason why in warm autoimmune hemolytic anemia, the type of red cell problem or red cell morphologic change you get is spherocytes. Because if you think about it, a normal red cell, I think of it like a water balloon. Say you have a water balloon that's like this big and you fill it halfway full of water. If I set that water balloon on the table, what's it going to do? It's just going to flatten out, right? Just like a normal red cell does. You take that same water balloon and all of a sudden, or you take that same amount of water and you put it in a much smaller water balloon, in other words, a red cell that's lost some of its membrane, suddenly you got a much tighter fit. You've got a full water balloon, you set it on the table, it's not going to squish much, it's going to stay spherical, it's going to be a spherocyte. So that is the classic finding in warm autoimmune hemolytic anemia, and that in fact is one of the questions you should ask when presented with a warm autoantibody. So warm autoimmune hemolytic anemia, specifically, when you have a warm antibody and it is a warm autoantibody and it is causing hemolysis, it typically occurs in older patients in the 7th to 8th decade of life. I love this picture on the right just because I was looking for something that showed people in their 7th or 8th decade. However, I'm a little troubled by it, so let's put some bands on. Anyway, I left that guy that way for too long. I apologize for that. Anyway, when you look at warm autoimmune hemolytic anemia, about half the time we know why it happens, about half the time we don't know why it happens. If we do know why it happens, it's most commonly lymphoproliferative malignancies. CLL in particular is a classic. Other things that can absolutely do it, things like lupus and rheumatoid, and in fact HIV can do it as well. That is not an exhaustive list. That is just some of the more common things. And in fact, especially with lupus and CLL, for example, the hemolysis may predate the diagnosis. In other words, someone coming in with, like in the case I was showing you, with a warm autoimmune hemolytic process may be the first time anybody knows that they have a lymphoproliferative malignancy or lupus, for example. So that can absolutely occur. It's less common than we used to think it was, but it can occur. Boy, we could talk a while about why these things happen. Why does the body turn on itself? Why does the body start making antibodies against its own red cell antigens? And you can see there's a lot of stuff that people have talked about. Honestly, I'm not incredibly interested in that. What we do know is that one of the older theories that in CLL, for example, it was that the malignant clone actually made the antibodies against the self-antigens. That does not seem to be the case. But generally speaking, again, there's a lot of theories, and we won't spend any time on why it happens, just know, obviously, that it does. Well, what about the DAT pattern in warm autoimmune hemolytic anemia? As I mentioned, we're not going to do a DAT on everybody that walks in the door, but when you have a pattern that suggests something like a warm autoimmune process, you do your panel, your autocontrol's positive, you have a panagglutinin, et cetera, then we do a DAT, and it's appropriate to do. And generally speaking, about 90+% of the time, the polyspecific DAT is going to be positive. And in fact, most commonly, everything's going to be positive. Two-thirds of the cases, 2 out of 3 cases, excuse me, you'll also have anti-IgG and anti-C3 positive. Another 20% IgG only, and the weird ones that are kind of strange and hard to understand are the ones that have C3 only. And that may just be because the IgG is not binding very well, and it's kind of below the detection limit of the DAT test. Not sure, but generally speaking, the most common result that you expect to see is positive polyspecific with the DAT, positive anti-IgG, and generally speaking, positive anti-C3. Okay. Now, about 10% of the time, though, we'll get patients that present in ways that really look like warm autoimmune hemolytic anemia, except for the fact that their DAT is negative. And that's just weird. And that's a strange finding that really kind of freaks people out for obvious reasons. There's a lot of reasons for it. Generally speaking, the ones that we think most of are low antibody coding, as I said before. The antibody is just not present in a high enough titer to bring the test up to positive, but it's there enough to cause hemolysis. And in fact, you can actually get autoimmune hemolysis from IgA antibodies or IgM antibodies. What I've shown you is IgG, but if it happens with IgA or IgM, you may have a completely negative DAT, and it can look exactly like this, with the exception that the patient is presenting clinically like he or she has significant hemolysis. So DAT negative autoimmune hemolytic anemia is definitely, as I said, about 1 out of 10. It can occur. Reference labs are very well aware of this, and we're able to, well, I'll put it this way. Most reference labs don't have a lot of capability to do this themselves, but we have reference labs that we send. So reference lab can send to another reference lab to get what's alternately called a super Coombs, extended DAT, things like that, where it's actually analyzed for those low antibody coatings and IgA, IgM, etc. So I've mentioned that autoantibodies don't necessarily equal hemolysis. Let's talk about that a little bit. We really need to be aware of what kind of things actually suggest that the patient is having hemolysis. Well, obviously, clinically speaking, patients with pallor, weakness, fatigue, dyspnea, those are kind of classic symptoms of really any anemia, but certainly true in warm autoimmune hemolytic anemia as well. If you look in the laboratory, you'll see laboratory evidence of hemolysis such as the bilirubin and the LDH going up, the hemoglobin and the haptoglobin going down. One very common misconception about haptoglobin, I mean, everybody knows the trick question, if somebody gets hemolysis, which way does the haptoglobin go? You were asked that when you were a medical student, I'm sure. Everybody knows the haptoglobin goes down in acute hemolysis, but people have a tendency to think that haptoglobin only goes down in acute intravascular hemolysis, like ABO-induced hemolysis. It's not true. It actually goes down with extravascular hemolysis as well. Unfortunately, it's kind of nonspecific, and it's one of those things that we talk about more than we actually use in real life. Well, blood bankers do anyway. But it can be a useful tool. On the smear, again, you're going to see those spherocytes. Antibodies will be IgG with broad reactivity. Usually, they may occasionally show relative specificity, and this is something I want to point out to you because it's really important. Laboratorians can get hung up on this often as well. Sometimes you'll see these warm autoantibodies that when you look at them, when you look at the panel, and I'll show you a couple examples of this in a minute, when you look at a panel, rather than being uniformly positive across the board against every cell, sometimes they'll be stronger positive, for example, when little e is present, or stronger when little c is present, just as an example. That doesn't necessarily mean that that antibody is an auto anti-little e or an auto anti-little c. If you see positives, if everything is positive, it's just stronger with one of those there, usually that's what we call a relative specificity, and that usually has very little clinical significance. Occasionally you'll see them with absolute specificity, where it's only positive, for example, when little e is there. That's a different story, and we'll talk a little bit about how to handle those in just a little while. But relative specificities are pretty common. They're usually something in the Rh system, so that's important to remember as well. I haven't talked about the specific target of these warm autoantibodies, and it's in part because people can't totally agree on it. everybody thinks it's probably something in the Rh blood group system, probably something related to the underlying core structure of Rh. It's called the Rh-related antigen, because we know that people that are Rh null, people that lack every Rh antigen, are usually, the warm autoantibodies usually won't react against them. It's not really hugely important from any perspective, but that's probably why some of these relative specificity antibodies are stronger with different types of Rh antigens there. All right, so I think this really applies to both pathology residents and laboratorians. I think someone needs to have a conversation with the clinician when we find out about a warm autoantibody, and not really to educate them, because most clinicians that deal with warm autoantibodies are very well aware of what's going on, but just in terms of what we're going to do going forward, how we're going to figure out what steps we need to take to get ready to treat this patient. For example, things that are important questions, just really simple questions like, has the patient been transfused? Obviously, you'll usually know if they were transfused at your facility, but you want to know if they were transfused anywhere else. Second, you want to know what the clinician's plans are. Are they thinking about transfusion? Do we have to get a unit of red cells or 2 or 3 or 4 for this patient right now, or do we have time to do a workup? Because what I'm going to tell you next is that there's a workup that we generally will start that takes a while to do. It's not a 1-hour process. It's a multi-hour process to get it done and get it done well. So we really need to understand what our clinicians are thinking in terms of how this patient is going to be transfused. So as I said, both from the laboratory perspective and from a pathology resident perspective, you need to be aware of these things. All right. So when we look at these, I've already kind of shown you an example. Generally speaking, with warm autoantibodies, ABO and RHD testing are fine. You usually won't see interference with ABO and RH. Occasionally, but not usually. Cold autoantibodies do mess with ABO and RH a lot, but warm autoantibodies usually don't. And you'll see something that looks like this. This is a 3-cell liquid panel, happens to be with PEG, but whatever. Anyway, you get strong positive at the anti-human globulin phase, which is the indirect antiglobulin test phase. I hope you're aware of what that means, and that you've already seen this one with a strong positive with the gel. Now, how about on a full panel? Again, just an expansion of that antibody detection test to involve, in this case, 11 different group O donors, and looking to see how they look, or how their red cells react against our patient's serum. And I've just kind of combined a liquid panel here with a gel panel here, and again, pretty strong across the board positivity. I did this deliberately because gel tends to make the antibodies a little stronger than in liquid. That's not always true, but it's often true. But something like that is a pretty obvious and clear, most likely autoantibody. Again, you need more work, but that's what it looks like. Okay, I mentioned those relative things. So here's an example of a relative specificity. If you look at this, if you see, instead of everything being positive, you got a 1+ here on cell 3, and when you look over, you see, oh, look, little e is absent there. Everywhere else it's positive. So this I would call this panel a relative little e specificity. In most cases, it's not a separate allo antibody. In some cases, it may be related to. In some cases, there may be a problem with the e antigen on the patient. It may be a form of partial little e. We can get a lot deeper into those details, but we're not gonna today. But bottom line, generally speaking, most of these don't have a whole lot of clinical significance. In other words, you're usually not gonna go and try and find little e negative units for this patient because relative specificities have not been shown to make a clinical difference in how the patient responds or the likelihood that the patient will hemolyze. So generally speaking, you wouldn't mess with that. All right. Other times it's a little less obvious. If you look at this panel on gel, you can see rather than everything being wildly positive, you got some positives, you even got a little negative and some weak positives. Okay, well that is less obvious, and there's actually a really good reason for that. When you think about how antibodies interact with red cells, here's what you find. Autoantibodies love red cells. They're very, very happy binding to red cells. They love to grab onto red cells as quickly as they can. So when an autoantibody is being formed, if this autoantibody is being made and you've got, okay, these just the first batch of IgG antibodies that are autoantibodies, what are they going to do? Are they going to preferentially bind to the red cells or preferentially be in the serum where you can see them in your test tube? They love to get on those red cells first. Okay, the next batch comes out. Well, they're going to mostly go on the red cells, and maybe a little bit will sneak into the plasma. And then only when the red cells start to get more saturated will more of those antibodies be in your test tube where you can define them. So it's what I showed you before with the, wishy-washy, it's kind of there, it's kind of not. But when you do the DAT on cases like that, you will often find that DAT is really, really strong. That is a very common pattern with developing warm autoantibodies, and it's something you should recognize. Now, here's something that I have shared with people that have come to my website many times, and I think it's important for you to understand that, again, when you look at a panel, it's important for us to, if we can, distinguish something that's quote-unquote significant from something that's insignificant. So it's really important to get that because it's going to totally change what we do if the warm autoantibody is significant and if it isn't. So you hang with me and I will show you just how to distinguish. So here's an example of an autoantibody panel, of a panel with an autoantibody that caused hemolysis. So take a look at that, kind of burn that into your brain. You see it? Got it? Okay, so here's an example without hemolysis. You got it? Oh, okay, you missed it maybe. One more time. Okay, without. So it makes you wonder, can you predict hemolysis by the way the panel looks? Captain Obvious says, no, you cannot. You absolutely can't. So that is hugely important. I've been doing blood banking for 30 years, and I've gotten tons of calls from folks in the laboratory saying, this is really strong, this has to be significant. The answer is no, it doesn't have to be significant. It might be, but it might not be. I have seen really weak appearing ones causing dramatic, horrible hemolysis and really strong ones causing absolutely nothing. So it's very important to recognize that just the way the antibody looks on the panel does not predict whether or not it's going to be significant for the patient. It's a really important take home. All right, so in the laboratory I mentioned, once we identify one of these, and once we identify whether or not we have time to work on them, in other words, if the clinician is saying, I need to transfuse right away, then you need to make a decision and get the patient blood right away. Okay, fine. But if you have time to work it out, laboratories will do a multitude of different things. One of the things that they will do very commonly is called an elution. And elutions are really simple in concept. In an elution, you're basically taking red cells that are coated with antibody, and you're making those antibodies go from the red cell into the test tube. You're either doing that with a combination of temperature changes or chemical changes. You're treating those red cells to basically get the antibodies off the red cells and into the tube. And you're actually, by doing that, you're actually concentrating those antibodies. It's actually a stronger concentration of antibody than you get in the patient's normal serum. So you might see in a case like this, I mean, you look at this and you say, okay, across the board 3+ with a 3+ auto control. We do the elution and we run it and it goes to 4+. You're going, okay, whoopie-doo. I knew that was an autoantibody before that. That is not really all that helpful. Now, blood banks will do it. It's fine, not a big deal. But the cases where, in my opinion, where elution really helps is where you've got the ones like I showed you before. That sporadic, it's there, it's not there. You do an elution then, and it pops up like this. Then, now that's a helpful test for you right there. That's where elution really shows you this pattern really is consistent. And that's, in my world, in reference lab world, when we get cases like this, and one of my techs will call me over to take a look at it, one of the things I will always do when I see this sporadic positivity, and I'll tell you the truth, I'll do it even if this autocontrol is negative. I do elutions a lot, simply because, as I said, you have to think of the concept. The antibody is concentrated in an elution, and you may see a pattern that was not evident in the untreated cells. Whether you're working with gel or liquid with PEG enhancement or solid phase, doesn't matter. You can see this enhancement there. So elution is a potentially helpful tool, but it's fairly non-specific. Once you do an elution, okay, great. So we've got that. What do we do with that? Well, it's consistent with a warm autoantibody. So really, for me, the big question is this. The main question that we have to answer for our clinicians and for ourselves as we're choosing blood for these patients is this. If we get rid of this, whatever is causing this across-the-board positivity, if we get rid of that, are we going to see that behind it? In other words, if we get rid of the autoantibody, are we going to see this pattern that when you look over here, you see that's consistent with an anti-D? Obviously, anti-D is are usually pretty easy to identify, but it's important to recognize that you can completely miss it as it's masked by that overlying autoantibody. So that's the whole idea. If we get rid of the autoantibody, can we see an underlying allo? And that's really our main goal in the workup. And there are a lot of ways to do this. And over the years, there have been a lot of things published on how to do it. Some of them work, some of them, in my opinion, are a little scary. And the first one is the dilution approach, and that one's a little scary. When you're throwing in a bunch of saline and diluting the antibody, diluting the serum down, in theory, the thought process is that autoantibodies are going to be diluted more than alloantibodies. Alloantibodies are going to survive longer and be stronger. And that may be true, but it may not be true. The great Dr. Garrity published something in Transfusion in '99 that says basically 1 out of 4 alloantibodies are missed when you do the dilution method. So quite frankly, it's really nothing more, in my opinion, than an emergency strategy. You can do it fast, but you may very well miss something that's very important. On the other hand, the warm autoadsorption is kind of the main tool in the blood banker's arsenal when it comes to working up warm autoantibodies and figuring out if there is an underlying alloantibody. So let's just look through this particular case. In this particular case, you've got, again, the strong positivity with a positive autocontrol. Whoops, sorry about that. With a positive autocontrol. The DAT is 3+ positive with both poly and IgG. And this is really important. No recent transfusions. You cannot do what I'm about to describe to you if the patient has been recently transfused. You can't do an autoadsorption if the patient has been recently transfused. Here's how warm autoadsorptions work. Hopefully you'll understand why in just a second. So if you've got someone who has autoantibody in their serum, and you're trying to see if they have an alloantibody in there as well, the basic idea is you take the patient's red cells, you incubate the patient's red cells with the patient's serum, and obviously, autoantibodies, remember, they love red cells. Autoantibodies are going to jump on those red cells. It's kind of like putting a sponge into water. They just soak up those autoantibodies. You then remove the autoantibodies, and anything that's left behind in the what we call adsorbed serum, we could then test, put it in the test tube, test it against a panel, and we can see in this particular case, and I'll show you right there, post-adsorption, we've got, in this case, oops, positive there, positive there, positive there. That actually works very well with an anti-big K that you could not see before. So really, really important. That's a perfect autoadsorption, and that's what we're trying to detect. That's the entire reason for doing an autoadsorption, to try and find that. In this case, we would identify a warm autoantibody and an allo-anti-K. The patient would obviously get units that are negative for the K antigen from now until forever. More on that in just a few minutes. Now, on the other hand, if the patient has been recently transfused, then you've got a problem. Transfused 2 units of red cells elsewhere last week. So if you tried to do an adsorption, what are you adsorbing with? You're going to be adsorbing with a mixture of the patient's red cells and somebody else's red cells. That's not going to work. You cannot do it that way. And this is just showing you what the problem could be. So in that same example, someone with an autoantibody and an anti-big K, if suddenly they've been recently transfused, and say for example they got a K positive red cell, well, when you throw those antibodies in, and obviously you wouldn't necessarily know this up front, especially if the patient was transfused somewhere else, but if there are K positive red cells in there,